started, I'm going to introduce our Executive Director, Lou Enga, who's going to introduce tonight's speaker.
All righty, and I'm Lou. Most of you know me. And I also want to say, lovely Amanda, who's been kicking this off, she is our Community Engagement Manager, and we're happy to have her. So thank you all for joining us to welcome Dr. Todd Schirmer. And Dr. Schirmer is the Director of Behavioral Health and Recovery Services for the County of Marin. In this role, he oversees integrated mental health and substance use services for low-income Marin County residents who are either on Medi-Cal or are uninsured. Prior to his appointment to this role in August of 2022, Dr. Schirmer served as Division Director overseeing mobile crisis, forensic, re-entry, and diversion services for BHRS since 2019. Prior to that, Dr. Schirmer spent 10 years working at Napa State Hospital with positions including staff psychologist, senior psychologist, and forensic specialist. He has maintained a small private practice in clinical and forensic psychology since 2010. Dr. Schirmer earned a PhD in clinical psychology from Rosalind Franklin University, an MA in clinical psychology from the University of Hawaii at Manoa, and a BS in human development and psychological services from Northwestern University. Dr. Schirmer is a licensed clinical psychologist and a certified correctional health professional. And we welcome you, Dr. Schirmer.
Thank you, Lou, for that warm welcome, and thank you, Nami, for having me here tonight. It's great to see a number of familiar faces, some folks that I've talked to or emailed just today. I also see my former next-door neighbor, Linda Allen, here in the meeting, so great to see you all. So I have some slides to share with you all. I have probably about 20 to 30 minutes of material to present, and then hopefully we can have some engaging Q&A at the end of the presentation tonight. So I'm going to share my screen. Okay. All right, so here's what we're going to talk about tonight. So first we'll start off with an overview of the county's behavioral health and recovery services. Second, I'd like to focus the presentation tonight on the interaction between behavioral health and homelessness. As part of that, I want to talk about a number of new state initiatives that really do kind of put the focus there on homelessness and the role of effective behavioral health care in reducing homelessness. And then last, we'll talk about some specific BHRS homelessness activities. All right, so who is Behavioral Health and Recovery Services? So I'll use BHRS as the acronym. So BHRS is the county's public behavioral health agency. We provide integrated mental health and substance use care for people across the lifespan. We provide early childhood care all the way up through older adult care. Here's a little bit of a roadmap of how our services work. You can see that our services are a mix of county-operated and contracted services. Our budget is actually about 50-50 in terms of county budget versus funds that we provide to community-based organizations for care in that level. Most of our clients, or about half of our clients anyways, have co-occurring mental health and substance use disorders. So we provide services in many different locations. We have 3 outpatient clinics, 2 for adults, 1 for children, as well as 6 full-service partnerships, including 1 program that is co-occurring substance use and mental health. We provide services in the jail. We operate a crisis unit. And really, we're out there in the field trying to meet people where they're at to provide the best possible service. So who are we? So we have about 230 employees in our department. Our budget is just short of $100 million per year. As I mentioned, it's a mix of county-operated and contracted programs. Of those, 15 are county-operated, client-facing programs. Programs you may have heard of include HOPE, which is Helping Older People Excel, Odyssey, which is our homeless-focused full-service partnership. We also contract with over a dozen community-based organizations to provide services, prevention, early intervention. And we have over 12 sources of funding in our department. Largest sources of funding include Medi-Cal. Mental Health Services Act is another large, as well as County General Fund and I think more than 10 grants. We serve over 2,500 clients per year in our mental health programs, and then another 800 or so in our substance use programs. Of that, we serve about 19% of our clients are older adults, meaning people who are 60 years and older. So I put our services in kind of 3 general domains. So first is our outpatient services. So we provide outpatient behavioral health services for low-income people who have Medi-Cal and meet certain eligibility criteria for specialty mental health or substance use. So these are our clinics and our full service partnerships. So in these programs, we provide things like psychiatry, case management, substance use disorder treatment, psychotherapy, different kinds of peer and family partner services. So these are services that are limited to people who have Medi-Cal and are low income and meet these eligibility criteria. The second major bucket of our services is our crisis work. So we provide crisis services to any Marin resident who is in a behavioral health crisis, regardless of insurance status. And so we do that in 2 ways. So first, we operate a crisis stabilization unit. That's a 24/7 facility. It's there on the campus of the Marin Health Medical Center, where people can be taken on a 5150 hold for evaluation, stabilization, and eventual return home or referral to an inpatient unit if that level of care is needed. Our crisis stabilization unit has a maximum stay of 23 hours and 59 minutes. So if somebody does need ongoing care beyond that period of time, then we would look to make a referral to an inpatient unit. Marin Health Medical Center does operate a 17-bed inpatient unit there right next door to our crisis stabilization unit. And that's the most common place where we would make those referrals. Although 17 beds is not very many. And so we will also make referrals to any of a dozen or so hospitals throughout the Bay Area and beyond. We also have a mobile crisis response team. I'll be saying more about that during our presentation today. And that's a field-based team that does evaluations for people who are in a behavioral health crisis. They can provide transportation to the crisis unit as needed. So the third bucket is our prevention and early intervention work. And these are services that are designed to reduce the impact of behavioral health disorders for populations at risk. So again, this is not related to insurance status, but this is for larger populations, for people who are at risk of developing behavioral health disorders, either mental health or substance use disorders. Examples of those would be our Suicide Prevention Collaborative, some of our work with public health on OD-free Marin, and then our work in the schools. You'll hear me talk today a little bit about Proposition 1. Prevention is one of those categories of programming that will lose funding, will lose local funding if Proposition 1 does pass. The state will be taking on prevention work. So in order to get into services, we operate an access program. So this is a single point of entry for mental health and substance use services. Their offices are also there at the campus of Marin Health Medical Center in Greenbrae. Access is a place where people can get screened for general eligibility and then do a comprehensive assessment for eligibility for specialty mental health services or substance use services. If somebody is found eligible for specialty mental health services, then those services are provided by BHRS. If they are found eligible for non-specialty mental health services, those are provided through, used to be called Beacon, now it's called Carillon, or Kaiser Medi-Cal. So the difference there is that people who have a serious mental illness, along with functional impairments, that makes someone found eligible for specialty mental health. If their mental illness is less severe or they don't experience functional impairments, then that's when they would be found eligible for non-specialty mental health. So we do maintain a close relationship with Carillon, Kaiser, and Partnership Health Plan to ensure coordination of care for people who are crossing over into the 2 systems. Substance use services are handled a little bit differently in that people can go to Access for that initial eligibility determination, or they can go straight to one of our contracted providers who can do the evaluation there. I did want to highlight a few of our community partnerships because we really can't do this work without strong community partners, particularly in the area of crisis services. So 988 is our nationwide behavioral health crisis number. In Marin County, Buccaloo Programs operates the call center for 988. And this is really designed to be a streamlined single access point for crisis services in Marin County. And we are working closely with Buccaloo programs to ensure coordination. And when somebody does call 988 and they need our mobile crisis response team, for example, we have a direct communication line so that we can dispatch our team. The city of San Rafael has launched their SAFE team, and this is a crisis team operated by the Petaluma People Services. And these are first-line interventions for people who are experiencing homelessness or other types of behavioral health crises within the San Rafael city limits. We have an agreement with the SAFE team to share data and to determine when situations require SAFE versus when situations require our mobile crisis response team. We do see those as complementary services. Third is the county partnered with the Marin County Cooperation Team to apply for a state grant called the Crises Act Pilot Program. This is through the California Department of Social Services. And this is modeled after the SAFE team in San Rafael, but this is to provide alternative behavioral health crisis response in the Marin City and Southern Marin areas. Next is Casa Renee, and this is a crisis residential program also operated by Buccaloo Programs. So when people are leaving our crisis unit or our jail or any type of inpatient unit and they need a short-term stay, it's not an acute crisis, but it does require some additional ongoing care. Casa Renee is a 14-day program for folks stepping down. And then lastly, the Helen Vine Recovery Center is the county's primary detox center. It's also operated by Buccaloo. It's substance use treatment, and they do have 2 sobering beds that are available for law enforcement drop-offs. You'll hear me talk quite a bit tonight about housing and homelessness. So I do want to just share this chart about how we view housing for people with behavioral health conditions. On the top right corner are the most restrictive types of housing options, a state hospital being the most restrictive type of housing situation. And then going down the line, there are institutes for mental disease, crisis residential, and then all the way down to the least restrictive, which would be independent living. And it's always our goal to support people in achieving housing at the lowest level of care that they need for their success. And so we are trying to build out a continuum of housing at all levels of this chart. So a couple of recent successes that we've had. The Carmelita House was an MHSA innovation project that we launched in 2022. This was a 6-bed housing program. It's now an 8-bed. We have expanded that, and that's for women who are exiting the criminal justice system. 920 Grand is a transitional residential program for people moving out of institutional settings. So this one is up to 18 months stay. And then we are developing a new program called the 30 Joseph Court program, which is a co-occurring substance use and mental health treatment program. And that's up to a 45-day stay. So we're really trying to build it out at all levels here. The needs are great. I can't say that any one level do we have enough capacity to provide housing for all the folks that need it. Okay, so I wanted to talk a little bit about homelessness and behavioral health. There's been a lot of research in the last few years about the linkage between homelessness and behavioral health. So Stanford Institute of Economic Policy Research identified a number of factors that are associated with homelessness. High housing costs, inadequate shelter, long-term impacts of deinstitutionalization, as well as changes in the criminal justice system. This study also found that a large share of the chronically homeless suffered from drug addiction and mental health problems. Similarly, the UCSF Benioff study from last year identified that low-income, high cost of rent, as well as minority groups are overrepresented in the homeless population. And homeless folks have high lifetime rates of serious mental illness and substance use. The point in time counts. So at the federal level, last year, there were over 650,000 people experiencing homelessness in the US. That's the highest number since this federal government began counting. Marin County's most recent point in time count in 2022 identified 1,100 folks experiencing homelessness, which was an increase from 2019. And paid particular attention to the numbers here because almost half reported current alcohol and drug use. Similar numbers reported current psychiatric or emotional conditions. However, I do think it's important to note that of those folks who were experiencing homelessness in Marin County who were surveyed, only 21% reported that substance use was the primary condition that led to their homelessness, and only 13% reported that mental health was the primary condition that led to their homelessness. I see a through line in a lot of the recent state legislation around, for example, Care Accord, SB 43, Prop 1, where there's an emphasis on using behavioral health care as a mechanism to address the homelessness crisis in California. And I think it's really important that we do focus on enhancing mental health and substance use treatment, because as you can see, the numbers speak for themselves, that it is a huge factor. But I'll also argue that it's not the only factor, that it is only one piece of the puzzle in trying to address, to provide a comprehensive solution to homelessness in the state. So moving on now to some of the things happening at the state level. So I love this slide because it shows just how much has been happening here in California over the last few years around behavioral health reform. It's fairly overwhelming to look at, but you can see that there's new Medi-Cal benefits, for example. There's new laws focused on children and youth. There's infrastructure money. There's a reform to the LPS Act. There's new requirements around crisis response, as well as new huge initiatives like Care Accord. So we who are working in the behavioral health field are tasked with managing all of these new changes, integrating them into our local system so that we can provide high quality mental health and substance use care to our residents. I'm going to go through not all of these because that would take us all night, but I'll go through a few of these items in a little bit more detail. And I will try to make a link to how they are addressing homelessness. So here are the 5 that I'm going to talk about in some more detail. SB 43, the CARE Act, our mobile crisis expansion, Cal-AIM, so that's California Advancing Innovations Medi-Cal, so that's a Medi-Cal reform, specifically the Justice Involved Initiative, and lastly, Prop 1. Okay, so SB 43 was signed into law last fall. This is a reform to the longstanding Lanterman-Petrick-Short Act. The LPS Act is what authorized involuntary detention and treatment and ultimately conservatorship for people who have a serious mental health disorder and who are unable to care for their basic needs for food, clothing, and shelter. So that is the definition of gravely disabled under the LPS Act. And that's the definition we've been operating on for several decades. SB 43 made a significant revision to that definition, adding to a mental health disorder also to somebody who has a severe substance use disorder or a co-occurring mental health and substance use disorder. That's one piece. And then the other piece is that they're unable to care for food, clothing, shelter, and personal safety or necessary medical care. So it is a significant expansion in the eligibility criteria for involuntary treatment and ultimately conservatorship under the grave disability standard. So this law was signed in October, and it was originally designed to go into effect January 1st of 2024. Marin County, along with, I believe, 55 other counties, boards of supervisors, authorized a deferral of that implementation date for up to 2 years. So we felt that January 1st of this year was too quick to implement a change that was as substantive as this one is. Because we do need to develop new policies and procedures for detention and treatment of severe substance use disorders, determine how to make assessments for someone who's unable to survive safely in the community without necessary medical care, expand our workforce and training to complete these new grave disability assessments, develop new standards, and then perhaps most critically is development of capacity for involuntary substance use treatment. At this time, there is no involuntary substance use treatment in Marin County, and that is not a model that we have readily available to us in California. So that means our crisis unit, psychiatric inpatient unit, and then long-term lock settings will need to adapt to a new population and potentially build new facilities. So how does this relate to homelessness? So SB 43, as it was kind of rolled out at the state level, was very much focused on people experiencing homelessness who are declining voluntary treatment and are unable to care for their basic needs. And this does provide a new legal pathway for involuntary treatment for folks who do need shelter, personal safety, or medical care. That severe substance use disorder is now a basis for involuntary treatment. This is an expansion of conservatorship laws. And so one of the unknowns with SB 43 is what are going to be the downstream effects. People who are hospitalized with a severe substance use disorder, are they eventually going to be found to meet criteria for a long-term conservatorship and then need placement, typically in a locked facility? So the county has convened work groups with our local hospital partners. NAMI was invited, our patients' rights advocates were invited. We had one initial kickoff meeting to talk about SB 43 in Marin County. We're also participating in a series of state work groups to start developing policies and procedures, determine needs. Oh, that's what I just said. So we do expect some increased number of people being referred for conservatorship, although we don't really know if they will be found eligible for conservatorship based on the law. So that is something that will be determined as we go forward. All right, so CARE Act. I know this group has heard many presentations about the CARE Act, including from my colleagues most recently, so I'll go through this relatively quickly. So the CARE Act is a new civil court program that's focused on aiding people who have schizophrenia or other psychotic disorders who have previously been resistant or unaware of available treatment options. So really we see this as somewhere between somebody who is declining voluntary care, but doesn't yet meet criteria for involuntary treatment and or conservatorship. So it's somebody sort of in the middle who's not participating in voluntary treatment, but is not yet gravely disabled. This process is designed to be collaborative and provides a care plan with clinically appropriate community-based set of services and supports. So CARE is very specific. The eligibility criteria are pretty narrow. Someone has to be 18, they have to have a diagnosis on the psychotic, the schizophrenia spectrum, and be not stabilized in voluntary treatment. I won't go through all of this, but really it's for folks, as I mentioned, who kind of fall in that middle of not participating in voluntary treatment, but are not gravely disabled. So the county has long had an assisted outpatient treatment program, AOT. We launched our program, I believe, in 2017 or 2018, although that was more than a decade after Laura's Law became available to counties. And I see in many ways that CARE is an extension of AOT. They do have a slightly different eligibility criteria, primarily in how people come into CARE. In AOT, only certain qualifying people can refer people to the AOT team, whereas in CARE, the petitions go directly to the court. AOT has slightly broader diagnostic criteria, and that can be any mental illness, whereas CARE has to be a schizophrenia spectrum disorder.
Can I ask you really quick? I'm sorry to interrupt. What is AOT?
All right, assisted outpatient treatment, also
Thank
known
you.
as Laura's Law.
Okay.
AOT is very specific in terms of the need for a certain number of hospitalizations, arrests, or incarcerations, whereas CARE is much more broad, and that someone is not clinically stabilized. AOT can be, people have to have Medi-Cal, whereas CARE is much broader. They can have any insurance plan or no insurance. And one of the interesting requirements under CARE is that commercial insurance plans are required to reimburse the county for services delivered by the county to their members. In no situation is medication forced. However, in care, the court can order compliance with medication. And then there are slightly different timeframes in terms of how long the process lasts. So again, to link this to homelessness, so care has been framed as a potential solution for homelessness to require behavioral health treatment for people who otherwise would not seek it out. And then one possible consequence for people in care is that they may be sent for a 5150 evaluation, and if they are ultimately terminated from care, that termination can be considered in an LPS hearing, a conservatorship hearing over the next 6 months. So we do expect that the implementation of care in Marin County will result in increased number of people being referred for conservatorship and possibly placed on conservatorship, although that is also an unknown. So you may be hearing a theme with SB 43 in care is that we are expecting increased people to be referred to conservatorships, but we really have no idea at this time. We are expecting some increase in people that are in that type of long-term involuntary care and needing placement. But that will remain to be seen over the next few years. Okay, moving right along to mobile crisis. So hopefully many of you have heard that we do now have a 24/7 mobile crisis team here in Marin County. We officially went 24/7 as of December 31st of last year. We did this in response to a new state mandate that requires all counties to have a 24/7 mobile crisis service, and then now makes it a Medi-Cal benefit. So our mobile crisis is not just expanded in terms of hours, but also in terms of scope. So that includes the addition of peers and substance use counselors to our team. There's now a requirement for warm handoffs and follow-up within 72 hours of a mobile crisis encounter. So our team has launched in 2016. We've seen a gradual expansion of the staffing as we've applied for and received grants. We've used our Mental Health Services Act money to fund mobile crisis expansion. Last year, we answered 2,600 calls with our 6-day-a-week schedule. So we expect that to go up this year with our 24/7 schedule. In order to get to 24/7, we added 2.5 new substance use counselors to our team, and then have expanded our contract with the Mental Health Association of San Francisco for peer counselors. So right now we're looking at a total of 14 positions supporting mobile crisis. However, I will say those positions have been challenging to recruit for, and so many of them are currently vacant and in recruitment. So our response model is teams of 2. Each team will have 1 crisis specialist who is a licensed or license eligible behavioral health clinician, and then either 1 substance use counselor or a peer counselor. From 7 a.m. to 10 p.m., we'll have at least 1 team of 2 on duty. But during the afternoon and evening hours, when historically we have seen the highest call volume, we will have multiple teams on duty. Overnights will be covered by 1 staff person who is there in the office in person, and then 1 staff who's on telephone standby. The idea being that the person in the office can do telephone triage, and if there is a crisis that needs an immediate response, they have a colleague who can come from their home and respond in person. We are working closely with San Rafael Safe Team, as well as the Southern Marin, the new and forthcoming Southern Marin crisis team. We see these services, as I mentioned, as complementary. And so we, as the mobile crisis team for the county, maintain the 5150 authorization, but these other teams can do tremendous work in intervening with folks who are in crises that don't quite rise to the level of needing voluntary hospitalization. And we fund mobile crisis with a mix of things. Our Mental Health Services Act is a major source of funding. We also have grants to alphabet soup things that you see there. CHAFA is the California Health Facility Financing Authority. And that's a year-to-year grant that we use to provide mobile crisis for school-aged populations. And then CCMU is our crisis care mobile unit, which is part of the state's behavioral health community infrastructure project grants. And then lastly, we do expect in the future to draw down Medi-Cal revenue and potentially contract with commercial insurance companies to provide mobile crisis to their members. So mobile crisis is very much a service that interacts with unhoused individuals. So the team does respond to many unhoused individuals and they provide connection to care. They carry Narcan, they can provide Narcan, they can deploy it in the moment if needed. And then if somebody does need involuntary hospitalization, they have the ability to do that. Part of their needs assessment often includes identifying needed shelter or housing. And then they also will make referrals to appropriate agencies for future housing. For example, the Coordinated Entry System, Housing Authority, Center for Domestic Peace, Casa Renee, or the shelter at Jonathan's Place. And then, as I mentioned, we do work closely with our community partners like the SAFE team. Okay, so CalAIM Justice Involved Initiative. So CalAIM is California Advancing Innovations in Medi-Cal. So this is a massive transformation of the state's Medi-Cal system. So the Justice Involved Initiative is one piece of that. California is the first state in the nation to receive a waiver from the federal government to allow 90 days of billable services while people are incarcerated. So the 90 days pre-release are now, folks can have active Medi-Cal and receive services that the county can bill for. So as such, it's very much, we're learning as we go here, but correctional facilities can begin providing that billable healthcare as soon as next October. And they are all required to provide those services no later than October 1st of 2026. So this includes county jails and state prisons. Separately, county behavioral health agencies have a kind of a piece of this to provide behavioral health linkages for incarcerated people. So that's in addition to the in-custody services, this is for folks who are being released, and this includes an assessment for mental health and substance use disorders, and then handoffs to providers upon release from a custody setting. So we are building that team now. We are finalizing an implementation plan and a readiness assessment within the next couple of weeks. The state will review that and then hopefully give us the go-ahead to begin providing these services as soon as October 1st of 2024. I don't know at this time whether the actual in-custody services will be ready to go as of October 1st, but we, as the Behavioral Health Agency, will be ready for our requirement, which is the linkages on October 1st. So connecting this to homelessness again, better services in custody will lead to better outcomes upon release to the community. We often find in the behavioral health space that incarcerated people are more interested and engaged in treatment while they're incarcerated. They might be sober, they might recognize the impact of a mental health condition. And so we want to catch people when they're motivated and engaged and start offering those services and then providing a direct link to a community provider. There are additional two benefits for folks who have Medi-Cal called enhanced care management and community supports. And these are additional benefits through managed care plans that address the need of highest need Medi-Cal members. And an interesting particular benefit under the community supports framework is housing transition navigation, which could include deposits and other types of tenancy and sustaining services. Okay, so let's get on to Prop 1. So as of right now, there's still no answer on Prop 1. Last I checked, the vote count was about 20,000 votes separating yes from no. Statewide, there still are some votes yet to be counted. It looks like the state's probably going to go all the way until the last possible moment, which is April 5th, to continue counting ballots. So we don't have an answer on this. I will say that Marin County's vote count is very overwhelmingly on the yes side, and our Board of Supervisors has issued a support motion for Prop 1. We're one of, I think, only 5 or 6 counties that did support Prop 1. So I know, again, this group is well aware of what's in Prop 1, so I'll explain it relatively fast. So there is this behavioral health infrastructure bond, $6.3 billion. to construct, acquire, and rehab permanent supportive housing, treatment, and other types of outpatient treatment slots. And then there's a reform to the Mental Health Services Act. So right now, MHSA has 5 categories of funding. And under Prop 1, this will change to, I think it's 3 general categories, but there's a new category, 30% of the funding has to go towards housing. Additionally, it expands the population to include people who have severe substance use disorders. Existing MHSA allows for substance use treatment only when it is co-occurring with a mental health condition. And so this provides new eligibility for folks who do not have a mental health condition. The state is doubling their portion of the tax under Prop 1 from 5 to 10%. And they will be taking over the prevention and workforce initiatives that are both currently managed at the county level. It also significantly expands requirements for planning, data gathering, and reporting. So rather than just reporting on how we spend MHSA funding, in the future, we will have to report both to the state and to the community all sources of behavioral health funding, which could include county general fund, realignment, grants, opioid settlements, everything pretty much. Last is that we do use MHSA as a federal match for our Medi-Cal funding. And so there is a risk that that will be reduced because we're going to lose our overall amount of funding under Prop 1. So we may reduce our overall amount of Medi-Cal revenue we can bring in. So here's a chart I showed today during the budget hearings at the Board of Supervisors. So this is how the allocation changes will impact us here in Marin County. Our current budget is around $16 million or so in MHSA. That will go down a little bit under Prop 1 if it does take effect. The 5 categories under MHSA are going to be changed. And I think the key piece to look at here is this dark blue piece of the pie. So on the left side, that's our existing MHSA budget. So the dark blue is the community service and supports, quote, general system development. So it's more or less the other category. And it's a way that we're able to fund new initiatives, a lot of new programming. Our mobile crisis, for example, was in there. Some of our work with the criminal justice system. I would say it's the closest that we have in government structure of some sort of a discretionary budget. So that was around 37% of the budget at around $6 million a year. And on the right side is how that's going to change. So because housing is now going to take 30% of our overall budget, that dark blue slice of the pie is shrinking substantially by over $3 million. So that other category is where we're going to have to work with the community to reprioritize some of our existing services. And of course, this is just the average of the last 3 MHSA budgets. Future revenue it's a very volatile funding source, so unclear what that will look like over the next several years. So as we think about decisions that the community needs to make going forward, on the left side are things that are required under Prop 1. So full service partnerships are a whole new set-alone category under Prop 1, and that is a requirement. Early intervention, so services designed to reduce mental health or substance use conditions, particularly for children, are required. Housing is now required at 30% of our budget. All counties are required to do 24/7 mobile crisis and care court. It's not required that BHSA or MHSA funds that, but it is required that counties provide it, and this is the most likely source of funding. And then lastly, we have invested in a new electronic health record as we've transitioned our payment structure, so that is, we consider that a requirement. On the right side is the things that we know are no longer going to be funded at the county level. So they're shifting from the county to the state. So that includes our prevention work, some of our workforce education and training, and innovation. These are things that we can no longer do, or at least no longer fund with BHSA, Behavioral Health Services Act. So this middle group is really the larger category, and this is what we will be working closely with the county, the Board of Supervisors, but most importantly with the community to help prioritize going forward. So these are things that we have historically funded under our general system development money that is now going to be shrinking. That's that $3.5 million or so that is shrinking. So that includes some important programs, our peer and wellness programs, a lot of outreach and engagement, family member support, other treatment services like crisis residential and criminal justice related programming, as well as our general system development and staffing. We have data analysts, program managers. A lot of the positions that keep BHRS running are in that group. So what we think in anyways that, it's about a $7 million give or take here annually, that new housing category could be as much as $7 million, or at least that we need to shift about $7 million. What is great about both the MHSA and then this revised BHSA under Prop 1 is that it does require us to engage in a robust community planning process. And that helps us identify priorities. How do we balance existing service areas with, the promise of Prop 1, which is the development of new housing and homelessness projects. Historically, we have done community planning around 12 months before the expiration of a 3-year MHSA plan. Right now, our current plan is still in its first year. It goes all the way through June of 2026. So we expect, if Prop 1 does eventually pass, that we're going to start this a year early. So we'll start it next fall, beginning community planning. So that way we have a framework, a community-approved framework that we can look at our overall contracts and programming going forward. So one part about Prop 1 that I am particularly excited about is the $6.3 billion bond measure for new permanent supportive housing and treatment beds. Marin County has had some success applying for and receiving state funding for permanent supportive housing, other kinds of treatment programs. I mentioned 30 Joseph Port project that was funded out of Behavioral Health Community Infrastructure Project. We also received funding under the Behavioral Health Bridge Housing Program, which is a collaboration with Sonoma County for transitional beds for people who are in care court. So we are optimistic that we will be able to apply for and potentially receive funding under this new housing bed to expand our housing and treatment infrastructure locally here in Marin County. At this point, we're still waiting guidance from the state on what this is going to look like, how they're going to distribute this money, whether it will be allocations, whether it will be competitive grant processes. We just don't know at this point in time, but we are starting to consider what might be a need here in our community. And then we do anticipate pursuing funding. All right, so I think the last section I have here is to talk a little bit about what are we already doing to address homelessness within behavioral health. So BHRS is part of the county's Health and Human Services Department. So HHS is an integrated health and social services department, which includes public health, social services, behavioral health, and homelessness and coordinated care. So we're fortunate in that we've gotten to collaborate, particularly with our homelessness division, on a number of high impact permanent supportive housing programs here in Marin. Examples would include the 1251 South Eliseo project, of which I think 16 beds are funded through No Place Like Home, which was an MHSA affiliated program. And then all 41 of the beds at the planned 3301 Kerner program that opens next year are going to be for individuals with behavioral health disorders, and they'll receive services at our clinic, which is directly across the street. BHRS also provides services through the Shelter Plus Care program. That's the Housing Authority program for people who are chronically homeless and have a qualifying disability. As I mentioned, we've applied for and received funding through the BCHIP project, as well as the Behavioral Health Bridge Housing Project. Several years ago, we launched 2 different programs under our Prop 47. Prop 47 was one of the criminal justice reforms out there, and that provided funding for alternatives incarceration and behavioral health treatment. And so we had a Prop 47 House for 3 years that provided housing for a total of 14 women exiting the criminal justice system. And then just last year, we launched a similar program called Sparrow House for up to 5 people at a time who are receiving services in one of our collaborative justice courts. Carmelita House, as I mentioned, is one of we're very excited about Carmelita House. It's an MHSA funded innovation project. It's been there since 2022, and it's now 8 beds. If Prop 1 does pass, this is a program that potentially could be funded under the new housing category in MHSA. So even though it is an innovation project and has a time limit to it, we may be able to sustain funding on that. And then last, our sober living environment. So BHRS works with the probation department, and we contract with 6 different organizations who provide sober living or recovery residents in 17 different sites in the county. And there was 145 clients housed in those facilities last year. And then we also provide treatment for people who are unhoused. Odyssey Full Service Partnership is a wraparound services to unhoused folks. And that's psychiatry, case management, peer counseling, substance use counseling, provide job training, job placement as needed. It is whatever it takes type of program. So services are provided in the field, at the shelter, Jonathan's Place, or in partnership with Marin Housing Authority. Right now, Odyssey has over 120 clients in it. Actually, with our current MHSA plan, we're going to be splitting this program in 2 to create a new full service partnership called Impact South, and that will be focused on San Rafael and South with a particular emphasis on Marin City. Our transition and outreach team is connected to Mobile Crisis, and this is a short-term intensive linkage program. So it's for people who aren't yet enrolled in our services, but we're hoping to get them enrolled in our services. So it's designed for folks who are awaiting an eligibility determination, or they're just not quite sure if they want services. And so it's really designed as a bridge to get folks into longer-term care. And one of their key functions is assisting clients in maintaining their current housing or locating for a shelter. And then lastly, although it doesn't seem like a homelessness initiative, I would like to argue that our jail mental health team really does address homelessness in some critical ways in our system. Many people who get arrested and incarcerated are unhoused at the time of arrest, and our team does tremendous work upon re-entry to identify housing resources and options. And they can make referrals directly to homeless shelters, to Casa Rene or Crisis Residential Program, to one of those sober living environments. And they do collaborate heavily with the re-entry team to try to identify housing for folks upon release. Our goal is to always have someone have a place to go when they're released from jail. Okay, so just wanted to share this because we have used our MHSA funds over the years to fund permanent supportive housing. And you can see the growth of that housing over time. Starting in 2018, we only had 1 program, the Fireside program in Mill Valley. And I believe that's will just be 5 beds. But all the way up to next year, we expect over 80 beds for folks who are needing permanent supportive housing and associated behavioral health care. All right, so my last slide is just to summarize. First of all, thank you all for listening to me rattle through all of that. This is really a time of tremendous change. It's almost overwhelming, the amount of change that is happening at the state level. It really does impact our day-to-day work in many, many ways. And it is a challenge for all of us to keep our eye on the future and integrate all of these substantial changes. We are actively using our behavioral health funding to enhance housing and homelessness services while maintaining our other critical infrastructure, including, of course, our core behavioral health and mental health and substance use treatment services. And we are excited about some of the changes coming down because it will continue this focus on housing and homelessness, plus create opportunities for new and innovative treatment programs. I think in many ways, we're ahead of the game here as compared with other counties in that we do already devote a substantial portion of our budget to these high impact housing and treatment programs. But these changes are continuing to push us in that direction, and I think it will be to the benefit of our entire community. All right, so last, just a few key pieces of information. I will just flag the mobile crisis is not up to date because now that is a 24/7 program. And we would encourage anyone to call 988 in the event of a behavioral health crisis, get someone on the phone, talk through the crisis, and then if needed, an in-person response.